This is the stenosis and anesthesia. Important points. What about the history or the classical features of mitral stenosis? It's a progressive, lifelong disease. Okay, unless you treat it to correct and repair the valve by some means, it is a progressive disease, and it accelerates during the later years, and majority of them always have a history of rheumatic fever. So even if the patient denies having suffered from rheumatic fever, it is called subclinical rheumatism from which the patient could have developed this. So the first reason or etiology for mitral stenosis is rheumatic fever in our country, and especially in countries with low socioeconomic status. But there are other causes like SLE, carcinoid syndrome, infective endocarditis, atrial myxoma, congenital mitral stenosis, and massive annular calcification are other rare uncommon causes for mitral stenosis. And it is more common in female, and its presentation is usually in second and third decade, and slower progressing lesions can appear even at the age of 40 and 50, and usually isolated MS is more common, but rarely it can be MS with MR or AR also is there. And the methodology by which it appears is rheumatic fever is an immunological inflammatory disorder caused by the group A streptococcal pharyngeal infection, and it is a multi-system disease, affects the heart, joints, brain, skin, and the subcutaneous tissues, and it is preventable if you properly have a good hygiene, nutrition, and identify and treat it early. It can be prevented easily, and family history of rheumatic fever and low socioeconomic status are additional factors. And this is the body produces antibodies against the streptococcal antigens, and this cross react with human tissues because of the similarity in the sequence of amino acids. So there are certain um, similarity in the amino acid sequence between the antigens as well as our body tissues. So this immunologically mediated inflammation, which results in sort of autoimmunization or autoimmune disease nature, is causing all this problem. And the revised Jones criteria should always be told whenever they ask you for the clinical manifestations, the major and minor criteria. And this is how the major criteria are classified. It is arthritis, carditis, chorea, edema, and subcutaneous nodule. So that you can remember by this mnemonic factors. And the minor criteria are fever, arthralgia, C-reactive protein, erythrocyte sedimentation rate elevation, ECG prolongation. All these things are the minor criteria, and patient may have, these are all very rare common things, the nodules, subcutaneous nodules, and the palmar erythema. And the supportive therapy during rheumatic fever is bed rest, anti-inflammatory agents, and for long-term prophylaxis, you start them on corticosteroids and penicillin, as well as aspirin can be given. Then we can do some secondary prevention with penicillin, or if the patient is allergic to penicillin, you can give erythromycin 250 milligrams twice a day for usually 15 days. Continue for 3 to 6 months like that. And then duration of secondary rheumatic fever prophylaxis is lifelong. Rheumatic fever carditis from 5 years until 21 years, you have to continue this antibiotic therapy. And these are the normal mitral valve sizes, and that flow occurring through that, and the mean gradient, pressure gradient across the valve. And this is the pathophysiology, how it happens. When the valve size becomes less than 2 centimeters square, there is an elevated atrioventricular pressure gradient. And when the valve size becomes less than 1, which is called tight metal stenosis, patient develops a pressure of LA pressure of 25 millimeters or more, and this results in gradual pulmonary hypertension. And with this pressure load between LA and thing, that LA dilatation goes up to 10 to 12 centimeters. It distorts the depolarization pathway, which is the cause for atrial fibrillation as well as the congestive heart failure, because the atrial kick is not there. And there is a tachycardia, which also causes atrial fibrillation. All these things reduce the diastolic filling of the LV and elevates the left atrial pressure, which results in pulmonary congestion. And this will lead to reduction in LV filling, also leads to reduction in stroke volume and cardiac output. In moderate MS, cardiac output at rest is normal, but when the patient exerts, that time it becomes inadequate. Whereas in severe MS, the cardiac output even at rest fails, and that is the reason patient develops orthopnea or dyspnea at rest also. And left ventricular systolic function is normally well preserved because the volume received is very low and the muscles are not taxed too much. So the left ventricular function for a long time remains adequate. And the clinical features are all these things, as I told earlier. And due to decreased cardiac output, the earliest symptom will be EC fatigability and syncope. Then later on, with an increase in left atrial pressure, patient develops pulmonary congestion, dyspnea, orthopnea, pulmonary edema. And due to another mechanical effects are the Ortner syndrome, compression of the left laryngeal nerve, and atrial fibrillation, more common in especially older people. And RV hypertrophy and RV failure can produce chest pain, ascites, and edema, features of right heart failure. And the cause of death in mitral stenosis is usually congestive heart failure or systemic embolization, pulmonary embolism, and infection. And these are all the clinical findings you find with malar flush and all the faces, but not in our people with the darker skin. It is more common in the Westerners. And the pulse is regular, low volume, felt in all peripheral vessels. And left parasternal heave and RV hypertrophy they will develop. But if it is an atrial fibrillation, pulse will be irregularly irregular. And the tapping apex beat is common. Diastolic thrill and cardiac apex present lateral recommend question will be there. And the classical mitral murmur they describe. Associated murmurs. Sometimes you can hear associated murmurs. What are the associated murmurs? These are the two associated murmurs sometimes you can have. One is the pansystolic murmur along the left sternal border, louder during inspiration, which is because of the severe pulmonary hypertension. So if you can hear this murmur along the left sternal border, it indicates severe pulmonary hypertension, and that is called Carvalho sign. Similarly, Graham-Steele murmur, when the pulmonary valve develops a regurgitation, pulmonary regurgitation, then you will get a high-pitched diastolic murmur, which is a decrescendo murmur along the left sternal border, and that is the cause for that is the pulmonary regurgitation, which is called the Graham-Steele murmur. And when the cardiac output becomes very, very markedly reduced, then there is no murmur at all, which is called silent MS also. So sometimes they may ask you this thing. And complications, of course, all of you know all these anomalies, arrhythmias, left heart failure, pulmonary edema, and recurrent infections, all those things. And features of pulmonary hypertension are parasternal heave and a palpable S2. And the ejection systolic murmur over the pulmonary area also, which will tell you about the severity. Clinically itself you can find out. And the ECG changes are usually they notch T waves in the ECG suggestive of left atrial enlargement. So the right atrium and left atrium contract at a slightly different timing. So instead of being a single P wave, it becomes notched or what is called the bifid, and it is also called P mitral. And other anomaly is the atrial fibrillation may be there, and the RVH, right ventricular enlargement, which can be seen in the V1 and V2 very commonly. So these three things we have to look for in the ECG of a patient with atherosclerosis. And X-ray test will produce the classical left atrial straightening of the left border, and the double density of enlarged left atrium will also be there. And this X-ray is usually kept in the OSCE or in the afternoon session also. So always remember this straightening of left border. They will ask you why that straightening happens, because of the prominent LA. It all fills up and it produces the straightening. Echocardiography is produced, and the cardiac MRI also is helpful in the assessing the severity. And the structure of mitral valve apparatus. Sometimes some examiners may be asking you, because especially if they are a cardiac anesthetist, they may ask you what is the anatomical structure of there is an annulus to which the two cusps of the valve, the anterior and posterior cusps are attached, and these cusps are activated by the capillary muscles which are attached to the cauda tendinae. Cauda tendinae attached to the capillary muscles. These are the things. And there is a Wilkinson score to find out the pliability, the possibility of doing a balloon valvuloplasty. So for doing a balloon valvuloplasty, you require a soft and supple valve which can be easily broken or split. So that is very important for this. And the causes of atrial fibrillation, this is the mnemonic that you can remember: alcohol, ASD, rheumatic fever, ischemic heart disease, thyrotoxicosis, hypertension and hemosiderosis, mitral valve diseases, chronic infections, and cardiomyopathy and chronic lung infections. So these are the things that you can remember as a causes. And patterns are paroxysmal, persistent, long-standing, persistent, and permanent AVF. And there is also a condition called low atrial fibrillation. And symptoms: patient may be symptomatic with palpitation, dyspnea, chest pain, dizziness, or they may be totally asymptomatic also with an irregular yellow preference. The consequences are commonly thromboembolism, when there is a reduction in the quality of life. Sometimes it can be the cause of mortality and impaired health condition. And the lack of P waves. How do you diagnose atrial fibrillation? These are all the findings. The fibrillatory waves may be between 350 to 600, but the ventricular response will be between 90 to 170. The QRS complex also becomes narrow, and you can find that irregular waves. This is how the whole pattern looks. You can see these are all the fibrillatory waves in the atrium. And the three pillars of management are rate control, rhythm control, and stroke prevention or thrombus prevention. So you can see this is the left atrial appendage. So this portion, even in normal health, is the least contractile portion. So the space is occurs more here, and that is the reason why the thrombus generates there. And this is the management of how do you do that reversal to sinus rhythm. Is hemodynamic instability. If it is present, you straight away go for synchronized cardioversion. But if the patient is hemodynamically normal with a known LV systolic function, then you go for amidrone. But if they don't have LV systolic dysfunction, then you can go for beta adrenoagonist, that is esmolol or metoprolol, and you can also try with diltiazem or verapamil. And if both these things do not succeed, then you go for digoxin ultimately. Digoxin is very rarely used here. And the anticoagulation guidelines, symptomatic atrial fibrillation, Less than 48 hours, you try to do a pharmacological cardioversion with a class 1 or class 3 drug. You get back to sinus rhythm, well and good. Otherwise, if the atrial fibrillation continuing, you do the electrocardioversion on the same day. But if the AF is more than 48 hours, first you start oral anticoagulation and then finally only you have to go for cardioversion. So less than 48 hours, first try to correct pharmacologically, failed you go for cardioversion. No anticoagulation within the first 48 hours. After 48 hours, first anticoagulation, then only cardioversion. This should have you very clear in your mind. And based on the guideline, these are the same things: rate control, maintenance of rhythm, and anticoagulation. These are the three pillars of the treatment. So mild cases, we manage them with diuretics and prophylactic treatment for rheumatic fever and infective endocarditis. In the presence of AF, so we have already discussed that. Then, if there is a tight mitral stenosis with pulmonary hypertension, surgical repair will be the ideal. And, the treatment, corrective treatments are pulmonary valvolectomy or surgical correction. These are the two things that you have to remember. So any patient coming with established mitral stenosis, if they require anesthetic management, these are our goals: PACARRI, that is preload, afterload, contractility, rate, rhythm, and prevention of ischemia. So maintain adequate LV filling, optimize heart rate. So rate should be always between 60 to 80, not more than that. That is the most important thing. And adequate LV filling, because if they especially are on diuretic, the preload may be very low. So you have to keep an optimal preload and make the preserve sinus rhythm, maintain contractility, and maintain SVR. That is, afterload should be maintained. If you make the patient vasodilate, then there will be not adequate cardiac output, so patient will have a hemodynamic instability. So avoid maintain SPR, avoid increase in PVR, and right heart function support sometimes needed if there is an established right heart failure also. And what are the medications you can continue? Diuretics to evaluate fluid status, drugs to control atrial fibrillation may need to be controlled sometimes. Watch out for potassium if the patient is receiving digoxin and diuretics. Warfarin, you may have to switch over to a short-acting drug if the patient is already taking warfarin for thrombus prevention. And preoperative sedation, you can give morphine because this is an ideal drug which will keep the pulmonary pressures under control. And you can give promethazine, which will have an antiemetic effect and it will potentiate the action of morphine also, so that you can reduce the dose of morphine. And benzodiazepine can be given for very sick people to reduce the tachycardia. Avoid atropine or glycopyrrolate because they can increase the heart rate. And for induction, you can use etomidate or propofol in titrated doses, or tapentone and midazolam. Narcotic of preference will be morphine and fentanyl. Rapid injection of propofol to be avoided. Even though here it is written avoid propofol, if you give it in a very titrated slow fashion, you can induce the patient with even 0.5 to 1 milligram, because their arm to brain circulation time also will be low. So by giving rapid propofol, you will cause more damage, but slow propofol can be given. Muscle relaxants of choice will be vetronium, because but with narcotics it can produce bradycardia. And rocuronium slightly increases heart rate, so you have to be very watchful. And you can use benzodiazepam intraoperatively also. Avoid halothane, which is an hallucinogenic agent. All the other drugs are used. Reverse, you have to slowly reverse the patient. If you are using reversal agent, don't give that rapidly. And monitoring, these are all the basic monitoring. Invasive monitoring is needed in patients who are very critically ill. And anesthetic management, post-op, you have to watch out for any evidence of pulmonary edema and right heart failure. And they may need a period of mechanical ventilation, especially patients who have established pulmonary hypertension and a mild degree of right heart failure. It is always better that they are ventilated 24 to 48 hours and till the pressures get adjusted. And these are the things that happen in pregnancy. Increase in heart rate is the first thing, and then increase in fluid. All these things cause the MS to get an elevated filling, uh, left atrial filling, and decrease emptying. And it is fixed cardiac output state. The pressure gradient start increasing with the pulmonary congestion, and especially after delivery, when the placenta is removed, there is an auto transfusion of 500 ml to 1 liter of blood into the circulation. So whenever you manage a pregnant patient at the time of placenta removal, you have to slow down the intravenous infusion and preferably give a prophylactic dose of Lasix 20 milligram to avoid the sudden overload caused by this auto transfusion. And sometimes they ask you to draw the pressure volume loop. This is a fixed stroke volume and cardiac output. And it is lesser than the normal, and this is the way you have to draw that pressure volume loop also. And the anticoagulation, as rightly mentioned, up to 12 weeks you go give heparin. From 12 to 36 you go for warfarin, and after 36 weeks again you switch over to uh, uh, heparin. And this is the corporate score where you have to take into this four consideration: prior cardiac event, functional class, and reduced systemic ventricular function, and left heart obstruction. These are the four things that are taken into. So if there are no risk factors, the mortality is 5%. Even with one risk factor, it is about 27, and two risk factors, it is 75%. That is what has been stratification is done. And if you are going to allow vaginal delivery, then avoid tachycardia because of labor pain. So you need to give a good labor analgesia, epidural or combined spinal epidural, and shorten the second stage of delivery as much as possible by instrumentation. Always maintain left uterine displacement. Supplemental oxygen should always be given during even normal labor and delivery. Pulse oximetry should monitor the patient saturation. And fetal heart rate monitoring also should be done. In more severe cases, you may need a radial artery cannulation and pulmonary artery catheterization. And phenylephrine will be the drug of choice. Small boluses can be given. And for cesarean section, it can be epidural spinal, combined spinal epidural, or general anesthesia. So all that things we have discussed how to manage that. And, so here the goals and management of obstetric patient also: slow heart rate, sinus rhythm, avoidance of iodocaval compression, adequate venous return, adequate SVR, and prevention of pain, hypoxia, hypercarbia, acidosis, which all will increase the pulmonary vascular resistance and produce problem. And these are all the other associated alveolar lesions. General rule: these drugs, metoprolol, propranolol, diltiazem, are safe to use during pregnancy. Diuretics, furosemide, used to decrease pulmonary venous congestion, but care to be given, avoid over diuresis. And the mitral valvuloplasty can also be considered in severely symptomatic patients who are refractory to medical management. Surgical intervention is required during pregnancy. Intervention during cancer after organogenesis can be done, but there is always a possibility of premature labor, and fetal viability will be a big question. So it's always combined during the later period. So these are all the indications for balloon valvuloplasty. very much needed. So anesthesia for balloon valvuloplasty procedure performed under mild conscious sedation. Rarely patient has a tender septum and experience discomfort during transeptal puncture and might need anesthesia and more sedation. General anesthesia is needed only if the patient is uncooperative or unstable. And the GT is used as a guide for transeptal content resolution in difficult cases. These are all the things that we have to work for. Mitral stenosis.
So I think when it comes to cesarean section, we need to tell them that metrogen is absolutely contraindicated, and the use of syntocinon, which can produce tachycardia, and the use of carbitocin. And now the newer one is carbitocin and not syntocinon. We can
I
add
don't
that.
think anybody uses metrogen nowadays, isn't it? I mean, most of the physicians have stopped
Metrogen
using.
is not used, but there are some centers which still have it, sir. And in patients with the mitral stenosis, it's an absolute contraindication.
Right. Any questions or any additions, notes? Yeah. Risha, all clear?
Yes, sir. Yes, sir.
Sir, can we try vaginal delivery if the obstetrician says?
Yeah, mild moderate cases we can say. That is why I put that slide where you have to give good labor epidural and prevent the pain-induced tachycardia. The main problem in mitral stenosis is avoiding tachycardia. If you are able to manage that, and if the established pulmonary hypertension is not severe, they can do very well.
What will be the bad effects on the fetus and the newborn? What is the precaution we should consider in the newborn, sir? What are the complications that can occur in the newborn?
No, that's why if the left ventricular output is less than normal, less than 40% ejection fraction, it will be difficult for the fetus to grow normally. So there will be definitely intrauterine growth retardation, and mother will be always exhausted and tired. So those patients are not ideally the good candidates for a trial vaginal or a vaginal delivery. So it is better that you plan an elective cesarean and do the cesarean in them rather than allowing them to go into labor and produce a normal delivery. Whereas patients with a valve size of 2.5 centimeters square, they may not have much problem because they may be having a normal life with no dyspnea, no recurrent congestion or edema, all these things. So they can withstand all the normal stress. But only thing, the additional tachycardia we have to prevent by adequate pain relief. Supplemental oxygen should be given. It will not affect the fetus growth also if their valve size is very mildly reduced. And
Yes, thank you.